Hello friends, in order to our journey toward the academics of anatomy, we are discussing about the neuroanatomy especially. But in the keeping our mind that next month, maybe a month of first professional, I'm discussing some important topic belongs to the anatomy, okay? And some important practical topics for the anatomy. I'm starting from the bone of upper limb. When I am talking about the bones of upper limb, I am first of all starting this one from the solo bone of the arm, that is known as humerus. Okay, this is the arm, this is the forearm, and this is the hand, and this is the solo bone of the arm, that is known as humerus. Why it's known as humerus? Because there is a nerve which goes behind the medial lower part of the bone, and that is known as ulnar nerve. Sometimes you feel that the striking of the medial aspect of the elbow cause the tingling sensation in the hand, arm or hand, forearm or hand, and suddenly this emotion or this expression change into the painful reaction. Okay, painful reaction, and several emotions come on the face. So this is known as the funny bone or humerus. Okay, now to study the bone, we have to keep in our mind two things. Number one, how this bone is articulating with the other bones, what joints are this bone is forming, and second one is what is the anatomical position of the bone. Actually, second one is more important. First, that means how this bone is in the adjusted in the body in a supine position, or sorry, an anatomical position. Okay, when I'm talking about this bone, this is actually a typical long bone, and as our general anatomy says, a typical long bone having two ends, one shaft, and this shaft is divided into three border, three surfaces. Most of the long bone are vertically placed. Similar to this is also vertically placed in our body. If I'm sitting here, this bone is vertically placed in the body. Okay, and question for you is, what bone is not vertically placed but a long bone in the body? Okay, so this is the humerus. Now question number second arises, how we holding this one? We know there are two ends. Rounded end is the upper end, the expanded end is the lower end. Okay, rounded end is the upper end and the expanded end is the lower end of the bone. Number one. Number two, in the lower end there are two small fossa present anteriorly and one larger fossa. This is posteriorly. This should be posteriorly. This fossa is known as olecranon fossa. Why? Because the olecranon process of the ulna is accepted by this fossa. So this is known as olecranon fossa. Okay, two anterior fossa, one more laterally placed, this is known as radial fossa, one medially placed, this is known as coronoid fossa. Okay, so and there is a pulley-like structure is there. This is the lower end, this is the upper end. Upper end having a rounded area, this is known as head. A very small projection that is known as lesser tubercle, and there is a greater tubercle. In between them there is a groove that is known as intertubercular groove. So this is the upper end, this is the lower end, and this poses many a feature of the long bones, that is the two ends, three border, three surfaces. Okay, and the vertically placed in the body. Now coming to how it's articulating, the head is articulating with the glenoid cavity of the scapula and forming the glenohumeral junction or shoulder joint. The lower end is articulating with the radius and ulna bone forming the elbow joint. This is about the articulation. Above, this is forming a rotation, or this is articulating with the glenoid cavity of the scapula. Important thing is that the scapula, okay, same side of a scapula in my hand, this is the pear-shaped glenoid cavity. This is directed anterior, forward and upward, little bit upward. This is the typical position of holding the scapula. So to articulate this one reciprocally, the head is upward, backward and medially directed. So this rounded area is upward, backward and medially directed. This larger fossa will be posteriorly placed. Now I can't hold this bone this side, because if I am keeping in my mind all the protocols, head is directed upward, backward and medially, the olecranon fossa behind and the medial epicondyle more projected medially, I can't hold this bone on the left side. Either there will be the head outside or there will be the olecranon fossa anteriorly. Okay, if I am completing the protocol, this bone belongs to the right hand. So this is the right side humerus. Now the anatomical position is clear. This is the right side bone. How we have to hold? Olecranon fossa behind, head above, medially and backward directed, and this is the shaft. Okay, this is anatomical. How is articulating with the bone? Above glenohumeral joint, and below is forming the elbow joint with the radius and ulna. Okay, now we have to explain this bone, what are the structure in this bone and how we are going to explain the attachment on this bone. Okay, let's start with this one. There is a upper end which is rounded and there is a lower end which is expanded. Okay, the upper end having the rounded sphere shaped structure that is known as head, and it's articulating with this one. And now you can see this one. This is a larger sphere, and this is the smaller pear-shaped cavity. So a joint which is formed by this one, that is glenohumeral joint, having a high mobility, having more chances of dislocation. So God given, nature given us some kind of protection. That is the glenoid cavity having attachment of the glenoid labrum and the rotator cuff. You have to read about the rotator cuff. Kindly write down a rotator cuff in my box. Okay, let's talk about this one. This head, this upper end especially, where the meeting with the shaft, there is a neck. This is the neck. This neck is known as surgical neck. Okay, this is known as surgical neck. Now question arises, why this known as surgical neck of humerus? Keep this rule in your mind whenever we are talking about the surgical neck of a bone, that neck is most of the time is associated with some important other structures which are in relation with this surgical neck. And damage to this neck, because it's a one of prone area, damage to this neck can lead to damage to these vital structures and may present with the symptoms. Okay, so question is there, you can write in my box also, that what are the structures which are winding around the surgical neck? Here, the axillary nerve. Have you heard about the axillary nerve? Yes, this nerve, the axillary nerve, is the branch of the posterior cord winding round the neck from posterior aspect and supplying the deltoid as well as teres minor. Okay, this, if, and another thing is the circumflex. The word circumflex is if anybody is winding round, any structure is winding round. Again, the posterior circumflex humeral artery, which is a branch of the third part of axillary artery. And I am not denying anterior circumflex humeral is also there, and both are anastomotic. But I am not talking about the anterior circumflex, because in most of the cases, anterior circumflex humeral artery is a lesser in diameter, comparatively smaller into the posterior circumflex artery. So I am taking about the posterior circumflex humeral artery as well as the axillary nerve. Okay, two structures. If damage to this one, that will lead. So when I'm talking about the surgical neck of humerus, and I'm talking about that what kind of structure is winding around this one, that having a clinical importance. What kind of clinical importance here it is? Clinical importance is when surgical neck is fractured, axillary nerve may damage, and axillary nerve is giving three branches in this zone. One is supplying to the deltoid. Result will be the damage to the or loss of the movement of the deltoid. So that if you're asking a patient to abduct the arm, there is a problem. Okay. Number two, teres minor. Maybe not be clinical presentation, but the third one is it's supplying the posterior cutaneous nerve, upper cutaneous nerve arm. There will be loss of sensation in this area, and this is known as regimental badge. You can see regimental badge is stick here. Regimental badge, loss of sensation pattern. Okay, Axillary nerve, 3 presentation. Number 1, this is a deltoid, teres minor may be lost, and third one is the regimental bast pattern sensation lost, okay, in the upper posterior aspect of the arm. 3 presentation will be there. This is surgical neck. Now if you're talking about this rest of upper end, this is the head. What this was? This was surgical neck. Now this head is articulating. This head is making a junction with this rest of the upper end. I'm drawing with this blue line. Okay, blue line. This head is forming a junction with the rest of the upper end. This blue line denoting the anatomical neck. An anatomical neck is the neck where most of the time the capsule of the joint is attached. And here the capsule of joint is deficit in 2 areas. Number 1, you can see this groove. The muscle bicep brachii long tendon, which is arising from the scapular part, especially the supraglenoid tubercle, is with this synovial sheath passing through this groove. So no need of capsule. Capsule is deficit here. Number 2, capsule is fused 1 centimeter lax below. Why it is? Have you seen mother forming a sweater or a shirt? You can see there is a laxation here. If the laxation is not here, probably I will be unable to abduct my arm. To facilitate this abduction movement, capsule is laxing here. Capsule is deficiting at the area of intertubercular sulcus, and capsule is laxing below. And that is a lacuna also. If capsule is laxing below, chances of dislocation are more and more inferiorly. Okay. Though this was head and this was anatomical neck. Surgical neck, anatomical neck. 2 different necks are there. One neck is also explained in the theory, that is a morphological neck, and it cannot be seen until cutting the bone and seeing where the epiphyseal area and where the diaphyseal area is there. Okay, that cannot be seen grossly. So this is the surgical neck, this is the anatomical neck, this is about the head. Now I'm talking about this one. Look at this. I'm holding the bone in this pattern, and this is more anteriorly. There is a tubercle that is known as lesser tubercle. Anterior margin of the lesser tubercle is sharper, and this is separated by the greater tubercle by a groove. This groove is known as intertubercle sulcus. And yes, one structure we read that is passing through the intertubercle sulcus is the long head of the bicep brachii with the synovial sheath. Whenever it's contracting, how we are going to avoiding the bowing of this one? Because from the anterior margin of this lesser tubercle up to the greater tubercle, one ligament is holding this tendon, and this is known as transverse humeral ligament. So in a lower anterior margin of the lesser tubercle having an attachment of a ligament like this, and this is known as transverse humeral ligament. What is this doing? This is actually avoiding the bowing of the long tendon of the bicep brachii, which is passing through this one. Okay, so what other structure attached with the lesser tubercle? Ventral aspect of the scapula, giving rise to a muscle that is known as subscapularis. So here is the attachment of the subscapularis muscle, single muscle. If you are examination going student, you can compare it with the pelvic bone also, or the femur bone also, where the lesser trochanter having the attachment of ventrally originating muscle of hip bone, that is the iliacus and psoas. Okay, similarly subscapularis is attached here. Now very, very important point. Look at this tubercle. This is the greater tubercle. This is the greater tubercle. The upper part of the tubercle, this is the upper flat part of the tubercle. This is attachment. This is having an attachment of the supraspinatus. Supraspinatus. Okay. If I am going little bit backward, there is attachment of infraspinatus, and last third flat part is having attachment of the teres minor. Okay, the mnemonic is SIT. Supraspinatus, the infraspinatus, and teres minor. Now you can see the movement of my finger. If I'm putting my this fingers here, subscapularis on a lesser trochanter, the supraspinatus on a upper flat part of the greater tubercle, then this is known as infraspinatus, and this is teres minor. All the finger holding is most of them belongs to the scapula and attach on this one. So these are combinedly forming a cuff, tendinous cuff, that is known as rotator cuff. If bone wants to go above, or my bone wants to go above, this rotator cuff is hampering the dislocation of this bone. The first protection we discussed during the discussion of this bone was the first one was the glenoid labrum, and second is this, that is a rotator cuff. You have to read the rotator cuff. Rotator cuff is a very, very important short note. It's avoiding the dislocation, or it's protecting the dislocation of the glenohumeral joint from above. But again, below, the capsule is also lax. And only the sloping fiber of the tricep is helping below dislocation. So that is not sufficient protection. So chances of dislocation of this joint below is more. And then the head of the humerus can be felt in the axilla. Okay, that was the attachment of the this greater tubercle, lesser tubercle, transverse humeral ligament, and in between this intertubercle sulcus where my finger is going, the long head, tendinous head of the bicep brachii passing. Not only that, at the neck, anteriorly anterior circumflex humeral, posteriorly posterior circumflex. One ascending branch of the anterior circumflex humeral to supply the shoulder joint is passing and going upward through this one, and that is known as ascending branch of anterior circumflex humeral artery. So two structures are traversing through this intertubercle sulcus. Number one is long head of the bicep brachii, which is descending downward, arising from the supraglenoid tubercle, and one branch of the anterior circumflex humeral artery, which is ascending upward to supply the shoulder joint. This bicipital groove, or this intertubercle sulcus, having traversed by two structures. Now important thing is, this is also having the lateral lip. This is the lateral lip, anterior margin of the greater tubercle. This is the lateral lip, this is the medial lip, this is the medial lip, and attachment is on the lateral lip, a muscle, fan shaped muscle from this one going like this and attached here, that is pectoralis major, a pectoralis major, and on this medial margin there is attachment of teres major. Teres minor was somewhere on the lesser greater tubercle, posterior aspect, teres major, and in between them there is, in the floor, there is attachment of the latissimus dorsi. Mnemonic is a lady between two majors. That pectoralis major on this end, a bilaminar pattern attachment on this one. This one, there is attachment of the teres major. Pectoralis major and teres major. Listen carefully, two terms are there. And in between them, there is a latissimus dorsi. Latissimus dorsi. So, two important questions are there. What are the structure attached in this intertubercle sulcus or bicipital groove? And second important question is, what are the structures traversing through this one? Both are different. Okay, we complete almost our talk about this up end. Now we are talking about the shaft of the humerus. Shaft of the humerus. Okay, when we're talking about the shaft of the humerus, okay, by the anterior margin of the greater tubercle, we are drawing a line like this, and we are reaching somewhere in between two anterior fossa. Here, this is the anterior border of the humerus. Okay, I want to mark through another bone or chalk. This is the anterior border. Okay, this anterior border is reaching up to the lateral margin of the intertubercle sulcus, and find out in between these two fossae, radial fossae and coronoid fossae. This is the anterior border. How we are going to assess the medial border? Okay, medial epicondyle, we are drawing a line, okay, which is well demarcated, but as we are moving upward, it is ill defined. This border is known as medial border. Okay, now we are moving toward the lateral condyle and we are moving upward. So, okay, again it's ill defined, beyond the middle part of the humerus, but well defined in the lower part. This is the lateral border. So anterior border, which is a continuation of the lateral margin of intertuberous sulcus, and find out in between two fossae, that is anterior border. The lateral border, which is a continuation of lateral supracondylar ridge and somewhere faint in between the humerus. Medial border, medial supracondylar ridge, and again it's fainted because upper part of the humerus is rounded. Okay, so three borders, like other long bone, the typical long bone, three borders divides this bone three surface between the lateral and the medial posterior surface. Between this lateral and this anterior, there is an anterior lateral surface. Between this medial and this anterior medial surface, three surfaces, anterior medial, anterior lateral, and posterior. But again, I am reminding that all the surface are not well visible about the middle of the humerus. Okay, let's one more thing, very, very important thing. As we are looking toward this anterior border, just a projection in the middle which is going posteriorly as V shape. Okay, this is the V shape. And this is known as deltoid tuberosity. This is a structure having insertion of the deltoid muscle. Okay, look at this. This is the deltoid and this is the deltoid tuberosity. This is the deltoid tuberosity. And you can see this deltoid tuberosity is encroaching into anterior lateral surface. Now, if I am talking about the anterior medial surface, there is an attachment of the coracobrachialis muscle. Anterolaterally, tendon of deltoid. Medially, coracobrachialis. And question for you all people, very, very important. It given a BDC, it given a many books, that what changes occurs at this junction where the deltoid is attached, coracobrachialis is attached. Coracobrachialis is inserted medially, anterior medially, and the deltoid is inserted anterior-laterally. This is the middle of the shaft. And one change is I talk about this change, that the well demarcated borders are lapsing and shaft is becoming the rounded. You have to write, okay, kindly write for me that what changes occurs at this level in the arm where the deltoid is inserted and coracobrachialis as well as inserted. Okay, let's give a hint, another one. Complete anterior medial surface, complete anterior lateral surface and anterior medial surface. Below this insertion or V-shaped deltoid tuberosity, below, not above, giving rise to a single muscle. If I want to paint this one, I am painting like this. Okay, anterior medial. Okay, complete anterior medial, but below the deltoid tuberosity. This give rise to one flexor of the arm, and that is known as brachialis. Okay, friends, one very, very interesting fact is there. The flexor compartment of the arm having three muscles. The coracobrachialis, which was inserted in the humerus opposite to the deltoid insertion anterior medially. The brachialis, which is originating below the insertion of the deltoid tuberosity and attached on the anterior surface of the coronoid process, forming the floor of scapular fossa. And third one was the Tricep Brachii, which was neither arising from the humerus nor inserted in the humerus. Three muscles. One is inserted in the humerus, second is originating from the humerus, and third one neither originating and nor inserted into the humerus. Okay, that is interesting now. Okay, all flexors, all are supplied by the single nerve. Kindly write in a box about this flexor of the arm. The study is not fulfilled until unless you are answering a few of my questions. And in previous sessions, I asked you some question, but you did not answer. Kindly answer for me. Like and subscribe my channel also. Okay, let's further discuss about this, the shaft. And we discuss below the deltoid tuberosity, origin of the brachialis muscle is there, anterior medial. So, the story of anterior medial, anterior lateral is lapse. But look at this one. This is the This is the deltoid tuberosity, and this due prominent of this one, a groove is formed. A groove is formed behind this one. A groove is formed behind this one, like this. A groove is formed behind this one, and this is known as spiral groove. On a posterior aspect, above this groove, the origin of the lateral head of the tricep. Below this, where my thumb is, the origin of the medial head of the tricep, and from the infraglenoid tubercle, long head of the tricep. Three head of the tricep. Solo muscle from the posterior aspect is the tricep brachii, and this muscle is inserted in olecranon process. Okay, so posterior surface, nothing to worry, tricep. But important fact is this spiral groove, which was behind the deltoid tuberosity, was in between the lateral head and medial head. Okay, in a living person, actually this is between the lateral and medial head. But in a dry bone, it is just behind the deltoid groove, that is spiral groove. Sorry, deltoid tuberosity, that is spiral groove. This spiral groove having a two vital structure. One is the radial nerve, the nerve of the posterior compartment, as well as the profunda brachii artery, largest branch of the posterior compartment of the arm. So, if there is a spiral twisting and fracture of the bone, the radial nerve will be gone, and radial nerve supplying the extensor of the arm and forearm, and there will be a wrist drop. Okay, that is the spiral groove. So one was intertubercle sulcus or bicipital groove, another is the spiral groove. You have to remind in your mind what are the structure winding down the surgical neck of humerus, what are the structure passing through the spiral groove. All these are very, very important question, frequently asked question in this bone. Okay, shaft is over now. We talk about the shaft, surgical neck, anatomical neck, tubercles, lesser tubercle, greater tubercle, attachment over there, shaft. Okay, now coming toward the lower end. Okay, very small, we are covering this one. This is the medial epicondyle, and this is the medial supracondylar ridge. Medial supracondylar ridge. Okay, this is the lateral epicondyle, and this is lateral epicondyle having a lateral supracondylar ridge. There is a pulley, trochlea-like structure. Can you see this trochlea? This trochlea having a shorter arm and longer arm. Due to this, whenever ulna is articulating this one, actually this is moving toward outside, and this angle between the arm and the forearm is deviating like this one. So this is known as carrying angle. Here, this is the capitulum, and the radial bone is articulating this one. And whenever we are flexing, head of the radius is accumulated here, and coronoid process of the ulna is accumulated here. So this is known as coronoid fossa, and this is known as radial fossa. Whenever extended elbow is there, olecranon process of the ulna is accepted here. So this is known as olecranon fossa. Very, very important. Olecranon fossa is posterior. That we discuss in the just initiation of this discussion. Olecranon fossa. This is the olecranon fossa. We can feel the subcutaneously olecranon fossa, which is accepted here. This is the radial fossa for the acceptance rounded head of the radius, and this is the coronoid process, which is for the acceptance of the coronoid process of the ulna. This is pulley-like structure, which is more prominent on the medial side, lesser prominent on the lateral side, so that the ulna get deviated toward the lateral side. This is causing the carrying angle formation. Read about the carrying angle, that may be a short note. Okay, whenever we are flexing, hyperflexing, due to these fossa, the hyperflexion or extreme flexion can occur. If this bone is flat or projecting area is this one, probably the flexion is not proper here. Okay, and now coming toward the supracondylar ridge and its attachment. If I am talking about the medial condyle, the upper part of the condyle, upper 2/3 of the condyle, so this supracondylar ridge, giving rise to a muscle that is known as pronator teres. If I am talking about the lateral part, the upper 2/3 of the lateral supracondylar ridge giving rise to a muscle that is known as brachioradialis. Okay, read about this muscle. This is a favorite one of mine. If I can give the 3 number 4 marks short note on this one, because this is a very, very special class of muscle. This is arising from the extensor part, This is supplied by the extensor now and working, behaving as a flexor. This is brachioradialis, upper two-third part of the supracondylar ridge. Lower part giving rise to the extensor carpi radialis longus. Okay, similarly, pronator teres is arising here. Pronator teres from the medial supracondylar ridge. What about these condyles? What about these condyles? Not only that, these supracondylar ridge along with the borders giving rise to the intermuscular septum or septum, which is dividing the arm into different compartment. Okay, and what structure piercing the compartment, what anterior coming and posterior coming, that is a part of the gross anatomy. Let's discuss just about the attachment. Pronator teres muscle is the humeral head, especially. Pronator teres is also arising from the ulna also. Is having two head. So the humeral head of the pronator teres arising from the medial supracondylar ridge. Lateral supracondylar ridge gives rise to two muscles. Upper two-third brachioradialis, lower one-third extensor carpi radialis longus. Okay. Rest. This complete medial epicondyle giving rise to the flexors of the arm. And this lateral epicondyle giving rise to the extensors of the forearm. So, and these flexor and extensor are working on the wrist. Whenever you are doing such kind of action, hammering, tennis playing like this, very wrist in the extensor posture for the long duration. For the long duration, your wrist in an extension position for a long duration, a constant strain on this part can cause the bony inflammation, and that is known as lateral epicondylitis. That is known as lateral epicondylitis, and this is known as tennis elbow. You have heard the term. That structure, tennis elbow, was the disease. The one world famous batsman was suffering from the disease. Kindly write in my box who was the batsman who was suffering from this tennis elbow disease. Another one, if your wrist is constantly in flexion mode and you are doing such kind of job where the consistent flexion of the wrist is there and your flexor is straining in this part, that is known as medial epicondylitis, inflammation of bone again, and this is known as golfer's elbow. This is known as golfer's elbow. So tennis elbow if lateral epicondylitis. Medial epicondylitis, golfer's elbow. But if you are sitting like this, there is a bursa which belongs to the insertion of the tricep and that get inflamed. That is known as elbow, student's elbow. If you are sitting like this, this is known as constantly sitting. There is a bursa which is inflamed. All three conditions are different. Inflammation of this lateral epicondyle, lateral epicondylitis is known as tennis elbow. Whether hammering is there or any other functions, and this is known as tennis elbow. If the golfer's elbow, if your wrist in consistent flexor position and doing the job, medial epicondylitis or golfer's elbow. If the inflammation of the bursa behind the elbow, that is known as student's elbow. All three conditions are painful condition of the elbow. So, and not only that, if the student elbow is not just a student elbow, it's also known as policeman's march elbow. Okay, again inflammation of bursa is there. So three condition, three different pathological status and three different presentation. Never ever confuse in three conditions, that is student's elbow, golfer's elbow, this one. Okay, that was something about the humerus. Okay, and kindly go through, answer my question regarding this one. Okay, what are the structures, spiral groove and clinical condition. Write some short note, give some suggestion to my channels also. I'm expecting more and more subscription and liking from you peoples, so I'm doing some practical topic, covering of some practical topics. Thank you for liking my channel. Kindly subscribe. Thank you, friends.